are
Hello.
live.
Hello. This is the cath lab of Nanjing First Hospital. I'm Dr. Junjie Zhang, Vice President of Nanjing First Hospital. On behalf of Professor Xiaoliang Chen, it's our great honor to perform two live coronary intervention cases today through the medical streams. So let me introduce the first case. The prime operator is the Dr. Zheng Ge. So please, Dr. Zheng Ge, introduce your team and your case information.
Okay, thank you, Dr. Zhang. It's Dr. Zheng Ge. I'm really appreciated to here to navigate for midstream. First of all, I want to introduce my team. It's on my right is Dr. Xiaofei Gao, and the next is Dr. Chao, and our image technician is Dr. Pan, and our some of the nurses. Okay, I would like please Dr. Gao to introduce this case information.
Okay, this slide. Yes, it's my honor to introduce this case. Next. This is a 69-year-old male. He was admitted into our hospital 40 days ago due to acute inferior myocardial infarction. His risk factors include hypertension and type 2 diabetes. Lab examination shows eGFR is 62. His BNP is normal. ECG shows pathological Q waves in leads 2, 3, and AVF. Echo finds abnormal inferior wall motion and left ventricular ejection fraction 52%. This time, he was diagnosed as unstable angina and early MI. Next. 40 days ago, this patient underwent primary PCI due to acute myocardial infarction, and the two drug-eluting stents were deployed in right coronary artery. This is the final result. It's good. Next. Today, the target lesion is left coronary artery. From AP coronary view and spider view, we could find diffuse severe stenosis from distal left main to middle LAD, involving left circumflex and first diagonal with severe calcification. There are two bifurcation lesions, distal left main bifurcation and LAD first diagonal bifurcation. Next. According to definition criteria proposed by Professor Xiaoliang Chen, complex bifurcation lesion is defined as any one major criterion plus any two minor criteria. Definition 2 trial demonstrated that two-stent technique, especially DK crash, is associated with a lower risk of target lesion failure compared with provisional stenting during 1 year follow-up and 3 year follow-up after PCI. Next. So today, the syntax score for the patient is 29. We also calculate syntax 2 score. 4-year mortality for PCI is 7.9%. 4-year mortality for CABG is 11.8%. According to definition criteria, distal left main bifurcation belongs to simple bifurcation. LAD first diagonal bifurcation belongs to complex bifurcation lesion. Next. So today, our strategy is IVUS guided PCI according to ultimate trial. Based on the findings of IVUS, we'll maybe choose ROTA, IVL, or others for severe calcification. We also plan to perform DK crash for complex LAD first diagonal bifurcation and the provisional stenting for this left main bifurcation. Next. That's all. Thank you.
Okay, thank you, Dr. Gao, to introduce this case presentation. Let me summarize this case 40 days ago because the inferior MI we performed the primary MPCI for the right coronary artery. And today is stage PCI for left coronary artery. And from the angio, okay, can you show, today is the angiogram. This is right, okay, it's the right angiogram. We can see the two stent is panned very well, and TIMI flow is great. Okay, the left coronary angiogram, we can see the distal left main bifurcation involves the distal left main and the circumflex and the LD. Also, we can see the bifurcation, LD and two diagonal one, and we can see severe calcification from the distal left main to the middle AOD. So let me probably we can talk about this strategy. And first of all, I want to show the intravascular imaging to everyone.
Actually, Dr. Ge, from the today's baseline left coronary angiogram, actually you can see there is a two bifurcation. One is a distal left main bifurcation, another is the LAD diagonal bifurcation. From this spider view, we can see clearly distinguished the orifice of the diagonal and the orifice of the circumflex is very critical. However, the lesion length of the diagonal is quite long, just as you mentioned in the case introduction. It's a typical definition defined complex bifurcation lesions angiographically. However, for the distal left main bifurcation, although the narrowing of the circumflex osmi is still critical, but the lesion length is not so long, less than 10 millimeter. So from the angiography, I think it's a simple bifurcation. So I fully agree. Yeah, you just mentioned for this two bifurcation, it's individual decision making. For circumflex, I think for distal left main, I think a simple bifurcation provisional standing. For LAD diagonal, according to the definition criteria, it's a typical complex bifurcation lesions. So according to the definition, two trials, so two-stand technique, especially a decay crush, superior to provisional standing in terms of a 1 year or 3 year clinical follow-up. So, yeah.
Well, yeah. Thank you, Dr. Zhang, gave us some greater suggestion. Yes, is from the spider view, is distal nerve main is according to the definition criteria is simple bifurcation. But we can say the circumflex the wide angle, so maybe to advance the wire is very difficult to circumflex. So, but we can see this circumflex is not a big vessel, but that because the inferior the MRI for the from the RCA, so I don't want to miss loss this circumflex. We can see that the LD and the diagonal is a complex bifurcation lesions according to definition criteria. Also, we can see that diagonal one is a very, very big vessel. It's a very important vessel. So I want to initially to do the two-stand technique, especially for the decay crush technique. So, but another issue is very severe the calcification from the distal left main to the middle ALD. So, what's the strategy for this calcification? Ruta or this species or others, probably intravascular imaging give us some important information to guide us to use this tool. Okay. So I want to show that intravascular imaging IVUS to from ALD and the diagonal. Dr. Pan, can you show the IVUS imaging?
Okay, let me show the IVUS imaging. The first one we check IVUS from the distal LAD to left main. And here we can see this is this point is a distal LAD, and here the vessel is not normal. Then go back, we can see eccentric plaque. Then go and pull back, we can see the plaque area is more and more larger. And here this point is a distal plaque minimal lumen area, and the area is about 3.5 millimeters square, and the plaque burden is just 60%. Then go and pull back the plaque area and more smaller. Then go on here, we can see find this point. This point the plaque burden is not more than 50. Here we can to do the distal landing rule. Then go and pull back here, we can see the small diagonal. This distal landing rule is over the small diagonal. Then go and pull back, we can see calcified plaque. But the calcification angle is not more than 180 degrees. Then go and pull back here. We can see eccentric plaque. Then go on here. This point is the minimal lumen area. And here the area is just 1.5 millimeter square, and the plaque burden is more than 86%. Then go and pull back here. This is a proximal LAD. Then go and pull back. We can see the calcification angle is not more than 180 degrees. Then go on here. We can see the guide wire. This is the diagonal. The diagonal we are drawing LAD. And then here, this is the LAD and the diagonal bifurcation. Then go and pull back. This is a proximal LAD. And here, we can see the calcification angle is more than 300 degrees. Then go and pull back. This is the ostium LAD. And here, we can find the diagonal one we are drawing LAD. Then go and pull back here, near here, we can see the circumflex we are drawing LAD. And this point is the ostium LAD. Here, the area is about 6.1 millimeter square, and the plaque burden is about 65%. Then go and pull back, this is the POC, and this is the distal left main. And here, the distal left main area is about 5.3 millimeter square, and the plaque burden is more than 74%. And here we can see calcified plaque, but the calcification angle is about 180 degrees. Then go and pull back. This is the body left main, and here the body left main vessel diameter about 5.5 millimeter. Then go and pull back. Here we can see the ostium left main. This point is the ostium left main. We measure from the distal landing loop to ostium left main. The narrowness is about 64 millimeter. From the distal landing loop to diagonal and LAD bifurcation, the narrowness is just 337 millimeter. Okay, this is the first run. The second run, we check IVUS from the diagonal to ostium diagonal. And here we can see the diagonal vessel is not normal, and the vessel diameter about 3.3 millimeter. Then go and pull back, we can see eccentric plaque, and the plaque is more and more, plaque area is more and more larger. Then go and pull back, this is the ostium diagonal. The ostium diagonal area is about 2.2 millimeter square, and the plaque burden is more than 75. And the narrowness from the distal landing loop to ostium diagonal is about 13 millimeter. Okay, this is the baseline IVUS imaging. Thank you.
Thank you, Dr. Pan. Thank you for introduction. I've seen more information. Actually, based on the IVUS information, we can precisely define the lesion length and define the landing zone and also the stand size. But the most important is about the calcification, because from the angiographically, it's a typical severe calcification, and also the IVUS show at the proximal LAD, especially just before the orifice of the first diagonal, it's a circle superficial calcification. From this point, I think, Dr. Ge, what's your strategy for this severe circle and superficial calcification? You will choose low ablation or lithotherapy with IVL. We have a domestic T-wave device, or you just use a cutting balloon. I would like to have your option.
Okay, this is a great question. From this angle, we can see the middle LD is very significant stenosis, but from the in IVUS we can see calcification is mild. So, and the calcification all focused on the proximal LD. From this IVUS imaging, we can this about the 300 degrees calcification. But we can see the vessel size probably 3 millimeter, but we don't know have the any the rota bone to size to do rota ablation for this calcification. So I think the 2 wave less PC maybe it's a great choice for this classification. So we already for this T-wave is the Chinese chemistry and T-wave, and I want to do this for this classification. Okay.
Okay, go ahead, Dr. Ge. So they will do the lithotherapy with a T-wave device.
Yeah.
So according to the IVUS imaging, they selected a 3.5 by 20 millimeter T-wave balloon to do the IVR therapy for the lesion prepare.
Yeah, this is a 3.5 millimeter T-wave.
So because the baseline angio, although the lesion is critical, but the IVUS actually you can see they have cross, there is no any resistance. So they were directly advanced the IVR T-wave balloon without predilation. Yeah. So actually, you can see there is a two wire. One wire is in the LED, another is in the diagonal. This case, we use a femoral approach with a 7 French EBU 3.5, 3.75 guiding cassette to get strong support. I think go to spider view, we can see clearly. Yeah, to facilitate the balloon position. Yeah, you can small test.
Yeah.
Maybe. Yeah, I think it's good. Yeah. So, doctor, can you introduce the special teaching point for the IVL therapy for these particular calcification lesions?
Yeah, use T-wave. It's similar to the shock wave from the other country. But T-wave is a Chinese chemistry device. Is also we use this size. Choose size is important for use tool. Usually we use the IVUS intermugin. Okay.
太远了，是不是？是不是太远了？冒音。对。
OK， 这可以。
冒点音。再下去一点。
哦。
OK。Okay, we position the balloon just at the bifurcation site. So we inflated the balloon at 4 atmosphere. Then we started the first round. Okay.
Yeah, 4 atmosphere and yeah, 4. Okay.
4.
Now the T-wave balloon started to work.
那个
启动了吗？
启动。
启动。
So automatically the machine have start to give the give the shockwave energy.
Okay. This first run is done. Okay. 6. And the inflation is balloon 6 atmosphere. And we can check this balloon to show the
patient hemodynamic now is stable.
Yes.
Considering it's older MI, inferior MI cases, at this time we inflated the LED, I think the patient, that there will be some risk. So at this time we should pay attention to the hemodynamic. The BP is good.
Yeah, its balloon is the second round. Okay. 6 to check. Yeah, I think it's balloon expansion.
Yeah, compared to the baseline shot, I think the balloon size is enlarged, which indicate maybe the T-wave take effect. But I think we should advance a little to distal. Yeah, just at the carina site.
Okay.
And give additional T-wave therapy. Another 10 round lithotherapy.
6. Okay.
ST there is a little elevate, yeah, but the BP is still okay. Small test.
Right. Oh,
Will you go to the IO to check the position, IO cranial, or if you could check the distal balloon position to fully cover the calcific lesion? AP cranial, yeah. Yeah, okay. Okay, BP is good, BP is up. Yeah, a small test. I think maybe need a little distal advanced balloon. What do you think, Dr. Ge?
yeah, I think.
We should
But
take-
from this angel, probably all covers the calcium. Already covered.
Okay, here is good. I think it's good.
Okay.
We can up the balloon and do the lithotherapy
Okay,
again.
it's great.
Yeah,
It's great.
it's
Okay.
now it's good.
Mm.
And start again.
Yes.
Yes.
I think from the balloons shape, I think we have get superficial circle calcification crack. Yeah, good.
Good.
Nice shape. Yeah, I think.
Okay. We can check IVUS.
Sure.
Show that.
Yeah,
okay.
yeah. So now we check the IVUS to detect have we successfully to do the lesion prepare with the T-wave lithotherapy. The BP is okay. The patient is stable and no chest pain.
Yes. No, any chest pain.
Please give some GTN intracoronary. Be careful. Test. Yeah. So I think after IVUS check, we will perform DK crush for this particular LAD diagonal complex bifurcation lesions. So according to the IVUS image, I think the side branch stent we will choose 2.75 by 15. Yeah.
Yeah.
So Dr. Pan, please introduce the IVUS.
Yeah, from the IVUS we can see media dissection, and here we can see the guide wire. This is the LAD and the diagonal bifurcation.
Okay.
Media dissection.
I think we have get a nicer effect with T-wave IVL therapy. We have cracked the superficial calcification.
Finish.
It's
Maybe
okay.
here this is a crack.
Yeah. Okay.
Here, one find the
Yeah.
crack.
There's a crack.
Yeah, you see clearly. Yeah.
This
This is a distal. This is a middle LAD just beyond the diagonal or before the diagonal.
Before.
Before. Okay. So.
Yeah.
Yeah, nice. You can see at it's 4 o'clock to 5 o'clock. Yeah.
Yeah.
Okay.
So,
doctor, what's your next
say
step?
I think this calcification already prepared very well. So I want to do the DK crush for this diagonal for this bifurcation. First of all, I want to use the 2.5 semi-compliant balloon to pre-dilate this diagonal ostium.
Okay.
So then I use the 3-point non-compliant balloon to pre-dilate LAD. Okay.
So after lesion prepare the ostial diagonal, then we will use 2.75 by 15 Jackie-Luding stent to treat the diagonal lesions.
3.0 non-compliant balloon.
So before we put the diagonal stent, I think we should first fix the mid-LAD lesions. Actually, is the critical lesions, but from the IVUS image, actually the calcification degree less than 118, so no need to the special low ablation or IVL, just with NC balloon to do the lesion prepare.
Yeah, I use 3.0 non-compliant balloon to pre-dilate LED. Here, okay. Here is
Small
middle.
test.
This test. Okay.
Yes.
Yes.
You can see.
Yeah.
It's a critical
12,
lesion
12,
of a mid LED.
12. Okay.
There
Oh,
is sleep.
sorry.
Yeah, be careful.
Sleep.
Just gradually. Yeah, here. That's the right position. Gradually. No. Too proximal.
Two. Gradually.
Too proximal. I think you should advance a little.
6.
Yeah.
8. 10. Okay.
Test. Still, I think we need more distal to do the lesion prepare, I think. What do you think? We didn't,
okay.
You see? We shouldn't need a...
2.
Slowly. Yeah, slowly.
3, 4.
Be careful. 6.
5, 6.
8. 10.
7, 8.
10.
9, 10.
I think 12 is enough. Yeah.
Yes.
Okay, good.
做研究太浓了。Here. Okay. 12.
6, 8, 10, 12.
Okay. Done.
So I think
8.
considering we will put a longer stem at the middle LED, so lesion prepare is quite important to facilitate the stem crossing.
3年支架 3.0 33.
The first stem, according to the IVUS imaging, we will choose the 3.0 by 33 jacket loading stem.
Good.
Put a wire more distal.
Yes.
Yeah.
Okay.
Good. by 33 jacket loading stem, Ceramous jacket loading stem for the middle LED. Yeah.
Smoothly. Okay, here.
Yeah. To avoid the orifice of the diagonal, will you go to the aerial cranial? Yeah. From the aerial cranial, we can distinguish the bifurcation, LED and diagonal.
Yeah.
What do you think?
Yeah.
Still go to the spider view to recheck the position.
Okay.
Yeah, it's very important. Precisely position the stand. Yeah.
It's on the diagonal. Okay.
Yeah, it's good.
Okay.
How about the distal landing zone? Okay. Check. I think we still need to go to the distal landing zone. Yeah. Because from the spider view, actually we can go more distal. Yeah. Test, please.
Okay.
A little millimeter. 1 millimeter, 小肥. Yeah. Good. Okay. Up. Nominal pressure. What's the nominal pressure?
9. Yes.
9. Okay. For longer stem, we need a long time inflation to achieve the fully stem expansion. So at least 15 seconds. Yeah. Otherwise, the stem will be deployed. Maybe we should pull back a little and do the stem balloon post dilation. Yeah.
Okay. Are the 2.2 stem? Yes.
Yeah.
So what's the next step, Dr. Ge?
Is to want to put the stem in the the diagonal.
So this is a decay crush for the LED and diagonal.
Yes.
Complex bifurcation. The first step of decay crush is a side branch standing. So we choose a 2.75 by 15 jacket loading stand. For diagonal with a minimal protruding into the LED. What's the balloon for the crush?
And
what's the balloon size?
Based on the IVUS, to choose the 3.5 non-compliant balloon.
Okay.
To embed the LED to crush. Oh, sorry.
Should be careful the wire.
Oh yes.
I think we have enough time. Go to the IO granule. RL. To get to the distal landing zone. Then go to the spider view to get to the proximal truding. Yeah, point.差吗？先向支架，我估计差。
不是，我现在这个 wrong wire， change another wire。
2根导残了，慢慢不急，时间够的。不行，把这 DK crush 做完也是可以的，不要急。I think doctor feels some resistance when he advanced the stand. I think the reason may be the wire wrapped. So we should pull out the previous balloon. Then firstly we should insert the stand. For these bifurcation lesions, it's actually this is often phenomenon, the wire crossover wrapping. So which will increase the resistance when advance the device. So and I think another good option is to use something like a dual lumen cassette to facilitate the wire rewiring to the side branch to avoid the wire wrapping. Actually, you can see now the Dr. Ge advanced the side branch stand. Yeah. Before we deploy the stand, we should insert the 3.5 NC balloon for the crush.
Okay. Spider view.
Yeah, good. This is the first step of DK crush. The side brace standing should minimal protruding into the main vessel. So test, you can see. So I think more proximal. What do you think?
Okay, I think so.
Yeah. This is the only view we can see the bifurcation clearly. We can take a picture. What do you think? Yeah, go to the IO caudal there. From this view, we can definitely confirm we fully cover IO caudal or AP caudal, fully cover the ostimal diagonal. Caudal, Xiaofei. Yeah, you see too much.
Okay.
I think it's too much. What do you think?
Yeah.
More distal. Yeah.
More distal. The ones a little bit. So I think
here it's good.
Yeah,
I think it's good. Yeah.
Yeah, okay.
Yeah, good.
Information.
Okay. So first, we deploy the side branch standing.
Yeah. 6, 8,
8.
Okay. Good. So pull back the stem balloon a little bit to.
No, too much. Yeah. Yeah, up again. We can define this step as a side branch
10.
optimal. Use a stem balloon, or
12.
you can also choose a NC balloon to do the post dilate for the side branch stem. Make the side branch stem orifice fully expansion. Then take a picture. Confirm there is a no distal edge dissection. Then we can inflate the main vessel balloon to crush the side branch standing protruding into the main vessel.
Okay.
Good. Then OG, be careful the distal wire tip you see in the small side branch.
Okay.
Yeah.
To pull back the non-compliant balloon to crush. Probably we need move to the another view.
Spy view. Yeah.
Yeah.
Okay. Crush.
I think it's good.
8, 10,
6, 10, 12,
12,
14, 16.
14, 16.
Okay.
We will go to the IO code, recheck the position.
Okay.
We fully cover the POC zone.
Mm.
This step is quite important. Or AP code, Xiaofei. This step is quite important. You should use a proper sizing balloon to fully crush the stem segment protruding into the main vessel.
12, 14,
16, 18,
16,
18.
18.
Do you think we need more distal, Dr. Ge?
Okay.
Yeah.
Yeah.
It's good. Be
16,
careful.
16,
16.
12,
Yeah.
14,
18,
16,
18.
18.
Okay. Wire? Not the wire. Also.
12.
4,
Well, you
12.
see the balloon is a little sleeping. What do you think?
Yes, yes.
Maybe a 3.5 is too much larger compatible with the distal vessel.
From the IVUS imaging.
Be careful.
Here,
Here is
yeah.
very classification.
6,
12.
8, 10, 12.
Okay.
I think we should check the. Okay.
The section. Okay. Note here. And the rewire to the diagonal.
Okay. So after successfully balloon crush step, we'll do the first rewiring to the side branch from the proximal cell. We will use a third wire
So the wire.
to rewire the side branch. The previous jet wire, we leave it at the diagonal as a marker, which will also facilitate us from the angiography to do the proximal cell rewiring.
Hm, 有那么多东西，我都是拿跑了。 It's not easy. Yeah.
What's the wire?
With
Also,
rule.
Okay. It's a regular wire we used to rewire the side branch. It,
I think maybe some problems there.
some resistance.
Yeah.
To, so I think if there is some difficulty for the sideburn rewiring after balloon crash, I think at these times
Okay.
okay.
you see successfully. Another option is to use IVUS recheck.
Yeah.
If we have successfully achieve a fully crash, it's very important. If we did not get a fully crash, sometimes we will have a resistance or have difficulty for the side branch rewiring. I think the up trim is also okay.
No.
Actually, there are two big trim, yeah. The up trim and the lower trim, yeah. It's a very, very big diagonal. Is there a dissection? I think.
No.
No,
Yeah,
okay.
No.
It's a sunburn.
Because you see the wire is separated. What do you think? It's okay?
Okay.
Okay,
Yeah.
good.
Okay. So pull back this wire.
What balloon you will use to do the side branch dilation?
2.75
NC balloon?
NC balloon. Yes.
Yeah. Can you
And
tell us, is this a proximal rewiring from the angiograph, or you will choose IVUS recheck?
okay, we can check IVUS.
Please check the IVUS. So this is a very important. We'll check the IVUS
Yeah.
to confirm the sideburn rewiring is from the proximal cell. Be careful the distal wire tip. So at this time, we insert the IVUS catheter into the main vessel and auto pull back.
Oh.
Is there any resistance?
Yes. This IVUS cannot
Yeah.
go through this. Probably. And no. 3D 那个3.5高压
3.5高压，
或者3.0行。
3.0。
I don't know why.
So there is some resistance for the IVUS inserting into the LED. So I think maybe that after balloon predilation, there is some calcification crack. So
Use another.
we will use a smaller balloon, 3O balloon, to do the lesion prepare again. Yeah, you see.
Yeah.
So 3O balloon
16
cross the lesion and do
18.
the lesion prepare again. Maybe go more distal. Yeah. Yeah. Actually, we also can use this balloon to do the mid LED post dilation, because we have put a 3O stent in the mid LED. We did not do the post dilation. Yeah.
Okay.
14, 16.
Yeah, here post dilation. Yeah, okay. 16.
16.
Because I think time is limited, I think, Doctor, we can directly insert the balloon to the side branch.
Okay.
2.75 NC balloon to the diagonal and to do the post dilation of the optimal
16.
diagonal.
Okay.
And also this 3 balloon can use as an angle ballooning to facilitate the 2.75 balloon entering into the diagonal.
I don't know, this non-compliant balloon could be advanced side branch. Probably use the small balloon to open the stem cell for snake. Oh.
Will you use the angle balloon?
Angle balloon. Okay.
Put the, no, just a minute. We should put the diagonal wire more distal. We should prepare a 2.0 balloon, semi-compliance balloon.
Okay.
You see.
Okay. Non-compliant balloon. 2.0. Non-compliant balloon.
We can choose a smaller balloon.
新的，给我新的，不信自己别换一个，给我新的。
Be careful the wire tip.
Oh. Go.
More distal, I think, the stereo balloon. Stereo balloon more distal. Okay. So we do the angle ballooning technique to facilitate the side balloon entering into the diagonal. If there's still resistance, I think we should check the IVUS to see what happened. Maybe we should wiring from the another cell, yeah. Check the IVUS. At these times, I think the IVUS imaging is very important to check the rewiring point.
Okay.
Okay.
Open.
Yeah, I will pull back. Yeah, this is a guide wire. This is LED and diagonal bifurcation. Then pull back, we can see this guide wire.
Wire is under the stem struct.
Proximal cell.
Maybe
Guide wire is passing through the proximal cell.
Okay. Maybe we to change another stem cell.
Yeah, here.
It's a proximal cell. I think it's a right cell. What do you think?
Proximal cell, very proximal.
Proximal cell.
Yeah,
proximal.
just one stand.
So.
Yeah.
To wire again. Okay. To the spider view.准备个新的2.0去了。
Still the
Probably.
same here? What do you think?
Yeah, I think so. Probably just this. This.
Maybe a smaller balloon, a 1.5 balloon repair. Do you feel resistance for the wiring? No resistance?
Yeah, it's better than before.
Okay, so still use a 2 balloon?
Yeah, 2 balloon.
Okay.
Another one branch.
3.5个呀，8.0的。
Still use a 3.0 NC balloon.
3.0高呀。
Oh my god. This probably.
You see, still there is some resistance.
Yes.
So we will use a 3.0 balloon in the mid LED to do the angle bearing. Yeah.
Probably, I don't know. Okay.
对，小心，太远了，回来一点。对，锚定以后看能不能下去，应该可以。
一个，这是个 angle。Oh.
Okay. We choose a smaller balloon. Still, you can see 2 balloon is quite a lot of resistance. Yeah.
We use 1.5.
Yeah. It's a challenging case, especially for calcification lesion, bifurcation lesion. So sometimes we have this phenomena. So we should use a smaller balloon to cross the stent struct into the diagonal. So Samir, I think now time is 1 hour already.
Okay,
so maybe
okay.
you can go to another cath lab. I think Dr. Ye has already. So we can perform the case.
Okay.
So you can see we successfully cross the 1.5 balloon.
Okay.
Still use a 2.0 balloon.
2 balloon, yes. 2 balloon.